Good morning, good evening, good afternoon, wherever you are, and welcome to the 12th Ifso webinar, What You Missed in the 24th World Congress. We're going to start with a little bit of introduction by Dr. President. Welcome, Dr. Kao. Please go ahead.
Thank you, Ahmad. Welcome, everyone, to this 12th webinar of Ifso. I'm delighted to be here today to have a wonderful panel to introduce to those of you that were at the meeting and those of you who were not at the meeting what you've missed at the 24th World Congress of Ifso, which was held in Madrid from 3rd to the 7th of September. This World Congress was the most attended Ifso World Congress ever in the history, with over 3,200 registrants. There was also a record number of abstracts that was accepted, 1,341 abstracts. 96 countries were represented at this meeting. There were also 450 speakers and 77 sponsors. What was great about this meeting was firstly the venue. It was held at the Municipal Palace, which housed the majority of the meeting, and everyone was housed in the same building such that it provided a great networking program for delegates, faculty, and industry partners. So for those of you who were there and missed out on some of the abstracts and the presentations, and for those of you who are not able to come, over the next hour, we're going to have a fantastic panel where I'm going to tell you what you've missed at this meeting. So over to you, Ahmed. Thank you.
Thank you, Dr. Kao. Excited for next year and your presidency. And this is a collective work of the entire communication committee. Unfortunately, two of them are missing. Hopefully, one of them will be able to later. I'm going to introduce the committee to you. Basker, Dr. Cynthia Borg, Ali Aminian, who's not able to attend, Hazem Al-Momani, Caetano Marchesini, Pedro Martinez, Hassan Shabir, Daher Toumi, and Abdurrahman, and myself. We had quite a turnout in the 2019 Congress. Brazil continued to dominate the non-local delegates. More than 1,300 abstracts. It's 378 oral abstracts. We're going to present 31. Lots of firsts again. The bariatric bullfighting, Ifso talks, bariatric mastership. Simulation continue to grow to add robotic surgery to it. And the breakdown of the abstracts, 25 multi-center studies, 30 randomized controlled trials, 35 clinical trials, majority retrospective, but growing endoscopic and new procedures, and more than 30 studies involving registries and national databases. What we're going to present today is 9 randomized controlled trials, 6 large multi-center studies, 5 prospective studies, 10 retrospective, 1 survey study, and in the handouts, you'll see 20 studies worth noting. So, without further ado, Hazem will discuss the first abstract. Hazem? Hazem seems...
Hello? Yes, no? Can you hear me?
Yes, we can.
All right. Apologies about the technical issues. Thank you, everyone. The first abstract I'm going to present has been considered by the committee as probably the most significant abstract presented in the recent Ifso 2019 at Madrid. It's quite a unique abstract, and it basically comparing 5 years outcome between laparoscopic sleeve gastrectomy versus a Roux-en-Y gastric bypass. While this concept has been touched before, this abstract has been the first to merge 2 prospective randomized controlled trials. The first one was the SM-BOSS, which is a Swiss prospective randomized trial, and the second trial was the sleeve pass trial, which is randomized multi-center, multi-surgeon trial from Finland. In this abstract, they presented their work when they followed 457 patients over 5 years follow-up. Their primary endpoint was the excess weight loss at 5 years. They also looked at the excess BMI loss, comorbidity resolution, quality of life, and complications. And the conclusions they've arrived to was that long-term weight loss was superior with the Roux-en-Y gastric bypass in comparison to the sleeve gastrectomy. And while there was no difference in the resolution of type 2 diabetes and obstructive sleep apnea, the use of medications for both dyslipidemia and hypertension was significantly less after the Roux-en-Y gastric bypass in comparison to the sleeve gastrectomy. When they moved on to talk about the quality of life, it was comparable between the two surgeries. And with regards to the complication, while the complication rates were higher after the laparoscopic gastric bypass, the severity of these complications were less comparable between the two groups. And that's it from my side.
Thank you, Hazem. And this stresses the importance of randomized controlled trials, and combining trials will add more statistical power and achieve results that are not apparent within a smaller number of patients.
Well, thank you very much, Ahmed. Thank you, everybody, for being with us, and it's a great opportunity to share what we have learned across time. I've basically looked at 3 abstracts, and I'm going to present the first one, which is basically management strategies for complications, and these are after one anastomosis gastric bypass. So essentially revision surgery, talking of one anastomosis gastric bypass, and there are 39 patients that they followed up, out of which 46% had bile reflux as a reason to reverse the OAGB, and 41 due to malnutrition. They converted 35 of them to bypasses, while 4 had complete reversal to normal anatomy. And the revisions were performed on an average about 36 months. That's 3 years after the one anastomosis bypass. And you can see that even after weight loss from the one anastomosis bypass was about, and on average, about 46 kilograms. However, this was lower in the group that required revision versus those who actually had conversion. Generally, weights and BMI, if compared to between those who had malabsorption and reflux, were lower for those with malabsorption. On the other hand, those who had conversions or revisions for malabsorption also had lower albumin levels and vitamin A levels. But what is striking in this paper is that if you look at the early and late morbidity of revision or conversion, it is 25.6%. and the late morbidity is 18%, which is striking, which is quite a lot, and there is 1 mortality in this group. However, reversal or revision of all these procedures did result in weight gain about 10 kgs in these patients, so some degree of reversal of nutritional inappropriateness, but not all of them got better. So you can see that another 1/4 of this population, or 1/3 of this population, still did not have benefit, even though they were converted to Roux-en-Y or normal anatomy. So stressing the need that certainly reversing one anastomosis bypass may improve clinical condition, but comes with a significant morbidity, with at least 1/4 of them experiencing early morbidities.
Great, thank you, Awesome. Which makes me curious about the way they converted to Roux-en-Y gastric bypass. Is it just taking the biliopancreatic limb down, or just biliopancreatic? Something to look forward in the article, for sure.
Yeah, I mean, how they did it, it's not mentioned in the method, but yeah, certainly something to look forward to the article. Totally agree.
Yes. Moving on.
Yeah, so the next one we picked up is basically an interesting paper, and this hails from Korea, looking at beta cell responsivity as a primary determinant of diabetes remission after Roux-en-Y bypass in non-obese Asians. So in Asia, non-obese individuals, patients below 27.5 is a big thing because we have a lot of diabetes population and they generally fall in the lower brackets. And here they basically used insulin sensitivity and beta cell secretory functions to study in patients with Roux-en-Y gastric bypass. And interestingly, what they found is that the magnitude of beta cell responsivity in early post-operative period is vital to remission. So again, indicating that if there are beta cells that can produce insulin, you would basically be able to remit your patients with diabetes and you will predict more. While insulin sensitivity per se has limited effect in this population. And as you can see, one of the markers that they used here is, where is that gone in the slide, is the disposition index, which is basically the insulin sensitivity with the production. So when you combine them, you have a disposition index and it doesn't change. But here, if you look at the short-term outcomes in 2 years, these patients, beta cell responsivity predicts for remission of diabetes, which is a great impact and possibly a way of hopefully in future predicting who will remit. The study population is not very big, but it is an intense scientific study. So I think the numbers are great in its own. 20 patients are more than enough.
Definitely one interesting concept to see from bariatric surgery in the non-obese population.
Right, so final one is the outcome of bariatric surgery in GAD, GAD-positive antibody patients. As we know, these antibodies are directed against the pancreas. So they were doing a randomized control trial, and during the trial, they tried to pick up these patients. They picked up 13 patients who are GAD antibodies. For those of us who do not know about GAD antibodies, these are generally picked up in patients who have LADA, which is latent autoimmune diabetes. This basically is an autoimmune destruction of the beta cell. So it's a type 1 diabetes, but presenting anywhere between 50 to 60 years of age. So it's not type 2 diabetes. Not so much of resistance, but of deficiency of insulin. And they looked at 5 years after surgery, even outcome in these patients. Normal values of GADA are generally, I think, below 5. And if you see that there were 3 who actually had normalization of their GAD antibodies, 2 had persistent antibodies and 1 did not repeat. They didn't repeat it, but they had good glycemic control. However, the results are reported are relatively short to draw long-term conclusions here, but there seems to be some degree of benefit, at least in terms of how patients can be managed. And even these patients had good control, and some of them even came off medications, while others continued to improve and maintain better glycemic control without treatment. So I think it sheds more light, and I think opens up more field that even in type 1 diabetes, bariatric surgery does actually help these patients.
Definitely agree with you. 2 types of papers in diabetes that will open up new fields of research, definitely, and looking forward to more trials and more results. Thank you very much, Asim. I know you have to leave. Thank you for contributing in the webinar, and safe travels to you.
Thank you. Thank you very much. Thank you. Thank you. Really appreciate that. Thank you.
Moving on to Cynthia.
Hi, everybody. It was a pleasure to attend the Ifso meeting in Madrid, and it's a pleasure to be able to tell you something about some presentations today. So I have chosen 2 presentations. One which is, I don't think we will be using in clinical practice, tomorrow, but which gives us some insight about how bariatric surgery works. So this is the first one. It's from Paul Davidson's group in the US. And can I have the first picture, Ahmed, actually? The first slide? No, it's going backwards. Yeah.
No. I may have
my first one.
misplaced it.
Okay, let me just tell you about it a little bit. Let me get it on my slide. So this is a study of 14 patients who had sleeve gastrectomy, and what the authors did was functional MRI 1 month prior to the sleeve gastrectomy, and then followed by functional MRI 12 months post-surgery. The authors have already described changes after Roux-en-Y gastric bypass. So there were 14 patients, 13 of which were female, and the mean BMI pre-op was 42. And in both times, in both visits, they also did the Dutch eating behavior questionnaire. So now we come to the results, which we can see on the screen. So what they found was that baseline functional connectivity of the right nucleus accumbens and the left hypothalamus predicted 12-month post-sleeve gastrectomy percentage weight loss. And there were also some changes, some baseline changes in some nuclei that predicted improvement in cognitive control of eating behavior 12 months post-sleeve gastrectomy. So again, a very interesting study that gives us a little bit of insight at what happens in the brain level after our surgery. We hear it very often, patients saying, oh, you know, it seems that you've operated on my head, doctor. My choices are completely different. And this is something that you know, gives us a little bit more understanding of what's going up in the head rather than in the abdomen. And
the one interesting study that completes the metabolic picture and effects of bariatric surgery, it's not only gut.
yes. This is another study that I chose. It's 190,000 patients from a registry, and these were all the bariatric patients that were operated and were entered in that registry between January 2013 and December 2017. And what they were estimating was readmission and where the readmission was. So in that period of time in that registry, 5% of patients were readmitted. Were readmitted at 30 days. Only out of this, a sizable percentage, 31.3%, were admitted not in the index hospital, i.e. where they were operated on, but in non-index hospitals. So in hospitals where they might not have had bariatric expertise. And unfortunately, patients that were admitted in non-index hospitals actually fared worse, i.e. their mortality was significantly higher. It was 3.4%, compared to only 0.2% of those who were admitted to the index hospitals. So what the authors concluded that about 25% of readmissions after bariatric surgery is directed to non-index hospitals, and the mortality rate is considerably higher.
That is definitely an interesting paper that shed light on the importance of bariatric training and doing these surgeries within the same practice. Even the follow-up should be within the same practice, or at least within a bariatric expertise hospital.
Definitely, and it also brings the issue of, you know, patients and patient education and the need to travel, you know, and maybe even things with ambulance practices that such patients should be sent to go to their index hospital rather than to just the nearest hospital with no expertise.
Yes, definitely raises a lot of questions.
Thank you very much.
And Cynthia? Cynthia is still with us? Oh, okay.
highest.
Sorry. So Cynthia had one more slide to look at, which is the risk model for venous thromboembolism. She had to leave, unfortunately. And basically, this is a MBS equipped database. Abdurrahman, are you with us?
Yes, I am. So I can talk about the study that we did. So basically, what we did is we reviewed the MBase equipped database between 2015 and 2017, trying to see if we can develop a risk prediction model that will show us which patients develop VTE. What the patients evaluated were more than 500,000 patients. The VTE rate overall was 0.17%, a little less than 900 patients. And what's interesting is when you look at the VTEs, which includes DVT, PE, and portomesenteric thromboses, more than 3/4 of them happened in patients with BMI and age less than 50, a group that usually not considered to be a high-risk group. And we found that if you've had previous cardiac surgery, you've had multiple drugs for hypertension, you've had previous foregut surgery or history of hypercoagulopathy, that actually was a higher risk for developing a VTE. We developed a risk prediction model and compared it to the two calculators that are present, the Berry Clot and the Cleveland Clinic calculator, and the area under the curve was actually better in our model to predict which patients will have VTE when you see the patients in the office and after surgery at the time of discharge. And the most predictive variables for VTE were multiple hypertension medications, being African American, being diabetic, having a high BMI, being older, and having obstructive sleep apnea. And we're in the process of developing that into a app that people could actually input their information and then categorize the patients to either mild risk less than 0.4%, high risk more than 0.4%, higher risk more than 1%, or the highest risk more than 3%, which will be hopefully coming in the future.
That's a great tool to have. Thank you, Abdurrahman. Definitely looking forward to that tool. So next is Hazem. Hazem, we're
Yes,
back to
Ahmed.
you.
Thank you. I've still got two presentations to talk about. The first one is a safety and feasibility study looking at the safety and feasibility of bariatric surgery in individuals who have had solid organ transplantation in the past. And in their introduction, the authors went on to say that individuals who have had solid organ transplantation are at a higher risk of developing obesity because of the immunosuppressant medications they're having and reduced physical activity. And the hypothesis was with that comes several comorbidities and it might affect graft survival. So they've conducted a retrospective analysis of the patients who underwent both laparoscopic sleeve gastrectomy and robotic assisted Roux-en-Y gastric bypass at their institute over a 2 years period. And they've only managed to collect data for 21 patients. The interesting thing is the results they've concluded was very much similar to what other studies have found, in that bariatric surgery is safer, there were no complications, the hospital stay is just average. Hello?
Yes, we can hear you.
Hello, sorry. I'm connecting through my phone, so I've just had a phone call.
No worries.
So the hospital stay was not longer, the complication rates were not higher. And what they've also found is that the graft function had improved by nearly 60% after bariatric surgery. So in their conclusion, they believe that bariatric surgery is safe and feasible. In individuals who've had solid organ transplantation and it improves significantly the obesity-related comorbidities and graft function.
That's great, and looking forward for more long-term outcome. Now we know at least it's not inferior for 6 months, and the complication rates are, but we do need more studies and more patients. Azam, you still there? So if you're there, just try to join us. This is another multi-center randomized controlled trial between Dudino switch and Saudis, comparing 88 patients between Saudis, randomized between DS and Saudis. And what this study found is a morbidity that is similar. Reoperation rate is a little bit higher in the DS as opposed to the Saudis. However, the weight loss seemed to be significantly higher in DS, but the nutritional outcomes were a little bit less in the Saudis group, showing a safety profile that is higher compared to the DS. DS still had a statistical difference after 3 years, and that is better. Anyone has any comment on this study?
Yes, please, Ahmed, if I may. I mean, the authors seem to have withdrawn some strong conclusions. They've only had 3 patients who developed complications, and they went on to label as one surgery being more risky or associated with higher risk than the others. I think we'd need more numbers to reach such a conclusion. But I think it is a start. It concluded similar to what we concluded from previous other studies. And as we said with others, it's only the beginning.
That is great. Thank you, Hazem. And moving on to Abdurrahman.
Thank you, Ahmed. So the first trial I'm presenting is a randomized trial from Frits Berends in the Netherlands. This is a group that has done many randomized trials in the past, including the Elegance and the Redo Elegance trials. So they randomized 130 patients at one center to having a standard bypass, Roux-en-Y, versus a banded bypass using the minimizer ring. And they wanted to look at the follow-up at 3 years. So after 2 years of follow-up, the banded Roux-en-Y gastric bypass had 89% excess weight loss, which is more than what we expect usually at 2 years. And the standard had a Roux-en-Y gastric bypass had 84%, and they were similar. Also, the weight regain in both groups, on the banded and the standard, was similar. There was dysphagia and removal of the ring in 8% of the banded Roux-en-Y gastric bypass, and there was no difference in complications and nutritional deficiencies. Knowing this group, I know that the group of Frits Berends performs a longer biliopancreatic limb Roux-en-Y gastric bypass. So it's not a surprise that the standard gastric bypass has 84% excess weight loss at 2 years, which is more than what we expect usually. And next, so I think we'll present this one and then maybe we can discuss them together. This is the group of Fink et al. They looked at exactly the same minimizer but in sleeve gastrectomy patients. And this group actually presented their randomized study earlier data at 1 year in the past. It's 9 patients comparing sleeve gastrectomy to sleeve gastrectomy with a minimizer band. You notice that the size of the band is 7.5 centimeters. So this is not very tight on the sleeve. And you notice most of the patients were super obese patients. So pre-op BMI was, the mean was 50.9 and 50.7. They had no complications in either group. 2 patients from the banded group and 1 from the sleeve group were converted to Roux-en-Y gastric bypass at 3 years. They did not see the reasons for conversions, whether it's weight regain or complications. The excess BMI loss was 75% for the banded and 64% for the sleeve, and regurgitation was the same. Now, this is similar to the 5-year study that was done by Phoebe and Mohit Bhandari that was published recently showing that banded sleeve has a better weight loss outcomes with no complications at 5 years. But it seems like it is not the same for Wound-wide gastric bypass if you lengthen the biliopancreatic length.
I agree with you, and I remember presenting the 1-year results actually in last year's What You Missed in Dubai, and there was a difference in regurgitation. However, there was no difference in weight loss, and it seems that the longer you go, maybe the band adds the weight maintenance of weight loss, let's say.
Agree. So the next trial is looking at TAP block for perioperatively from the group of Ruiz in Spain. They randomized 140 patients after one anastomosis gastric bypass to either receiving TAP block or not, 70 patients in each group. The OR time was about 75 minutes in the TAP block and 70 without the top block and 78 minutes in the top block, so not much difference. The main post-op pain by visual analog score was at 6 hours was 23 in the TAP block and 41 in the control group, and that was statistically significant. And 24 hours after surgery, it was 16 in the TAP block versus 35 in the control group. And the morphine rescue was necessary in only 3% of the TAP block and about 13% in the control group. So they felt that this was statistically significant. And we've had similar experience ourselves since using the TAP block. So this is something that was introduced in 2007 by an anesthesiologist. Used to be done ultrasound guided. Now most surgeons do it laparoscopically, and it's very effective.
That is great. Thank you, Abdurrahman. So my part, this is an interesting study done by Christine Steyer and colleagues that looked at two groups of patients, 236. Group 1 was below 150 kilograms, group 2 more than 150 kilograms, and they received different doses of enoxaparin, 40 milligrams twice daily as opposed to 60 milligrams twice daily, and that's based on the theory that the dose should be according to weight. And they measured the anti-factor 10A on the third day after administration, and they found that a huge portion of patients do not reach the therapeutic levels that are needed, and only the anti-factor 10A is the only objective way to actually predict the dose of enoxaparin.
I think this is an excellent study, Ahmed, and this actually highlights that in our bariatric surgery population, we cannot predict which type of prophylaxis patients need just by looking at BMI. We have to use an objective measurement, and we often use anti-factor 10A, and we usually don't check on the third day. We usually check it on post-op day 1 after the third dose, 4 hours after the third dose, and we aim for 0.2 to 0.4, and then we make adjustments. So I think it highlights that in the bariatric surgery population, you need to measure anti-factor 10A because the clearance is different in patients. Really excellent study.
Definitely agree with you. Moving on to the next one, which is a multi-center, multi-country, more than 1,600 patients who underwent ellipse gastric balloon, and the mean age was 39, mean 34, and majority of the patients actually were able to swallow. About 32% needed stylet assistance to swallow the pill. However, a small portion of patients did not reach the ultimate goal of having it for the entire length that it's intended to. 10 patients had vomited the balloons, 3 deflated early, 41 had intolerance with early endoscopic removal, that's 2.5%. Only 1 had severe esophagitis, and one patient had gastric perforation requiring surgery, but the majority achieved 13.6% total body weight loss, and that corresponds to almost 56 weight loss. With the safety of the new.
Despite the study being retrospective, I think it's an important study because it shows that in this balloon, which you don't need endoscopy to place, most patients can tolerate just having it done in fluoroscopy. And then if you look at the total weight loss, 13.6% is significant weight loss despite having a mean BMI of 34. And this is a group of patients that we currently can only offer medications. So I think an important study, and losing 13 kilograms is significant.
Yes, I agree. And I wonder if they did pre-insertion endoscopy in those patients, and if it would have mattered in the small portion of patients that could not tolerate it. Looking forward to the paper for sure. Randomized controlled trial looking at gastropexy with the ligamentum teres and hiatal hernia closure together in sleeve gastrectomy. It's a randomized controlled trial, randomizing 50 patients with hiatal hernia repair versus hiatal hernia repair and gastropexy using the ligamentum teres. And the interesting part is those patients actually had pre-op reflux and erosive esophagitis in the two groups, and none in the hiatal hernia and the gastropexy group had any GERD symptoms, any erosive esophagitis with a normal pH and a normal Demeester score 1 year after surgery. And the hiatal hernia repair was actually able to control these symptoms in about 60% of patients, so 40% still had erosive esophagitis with a high Demeester score.
I think it's an interesting study. I have one comment. I'm not sure how ethical it is to have someone with endoscopic esophagitis, objective evidence of reflux, and still do a sleeve gastrectomy. I mean, in real life, these patients, you need to discuss with them the option of having Roux-en-Y gastric bypass because it would improve them. However, it is an interesting topic, and there are surgeons who actually do ligamentum teres gastropexy for reflux after sleeve. I think that is something I would swallow probably a little better.
I agree with you, and it's probably a tool to use after sleeve gastrectomy, de novo GERD after sleeve gastrectomy, or worsening GERD after sleeve gastrectomy. But I agree with you, Roux-en-Y gastric bypass seems to be the better option in patients with severe reflux. And actually, this brings us to this topic, which is actually this paper will be our journal club paper next month. It's Matar and colleagues from the Mayo Clinic group with Barham Aboudieh that looked at 517 patients who underwent sleeve gastrectomy and Roux-en-Y gastric bypass with a long-term follow-up with endoscopies. So these are the two cohorts, 261, 256 Roux-en-Y gastric bypass, and the Roux-en-Y gastric bypass group had longer term follow-up. And once they scoped them, they found that severe esophagitis is actually present more in the sleeve gastrectomy group as opposed to the Roux-en-Y group. But the most interesting aspect of this study is more Barrett's esophagus in the Roux-en-Y group as opposed to the sleeve gastrectomy group long term. And the mean follow-up for the gastric bypass was definitely higher than the sleeve gastrectomy, which raises the question and concern about following up patients with Roux-en-Y gastric bypass as well. If they are symptomatic or not. That's the only thing that was not mentioned in the paper.
I would like to make some comment about that because I'm an endoscopist too, and I do have a large number of Roux-en-Y gastric bypasses. And I do really observe mild esophagitis in these patients, but usually is asymptomatic. And we do yearly or once each 2 years endoscopy in these patients to follow up. But one thing interesting, you talk about Barrett's esophagus here, is that maybe these patients already had Barrett's esophagus before the surgery, and they did it, bypass, just to try to treat the reflux. So if we don't have the numbers previous surgery, I don't think we do have here, we won't know if this evolved after the surgery or before the surgery, but still,
yeah,
probably
that's
these patients were made bypasses because they already had severe esophagitis.
definitely agree with you, and that's a question to raise to the authors next month in the next journal club for sure. Moving on, Caetano.
Yes, this is the second slide of two.
Yes,
so,
the Sunderland experience.
Okay, so this the first slide. These were divided in 2 slides because it was very large study. So what it states is that usually what we have been told and get some concern about doing surgery in patients that they do not have their diabetes controlled. So they got 3 groups. The first group, there was a group that did not have a glycated hemoglobin till 6.5. The second one from 6.5 to 8.5, and the third group from more than 8.5. And they did the surgery in all the groups. And what the final conclusion that is very interesting, they showed that there was no difference in the BMI of the groups, but the readmission rates were the same. And the 6-month and 1-year sustained were equal reduction in the glycated hemoglobin. So they really had a nice response in all the groups, showing that delaying the surgery because the diabetes over 8.5 or non-control is not really necessary.
That is quite interesting, and a good thing to know that these patients have the same complication rates as the rest of the population.
So I think this is something that we are used to hear about that from all the clinicians, that we think we should control it, but now we are seeing that we're having another very nice control of these patients. Another thing, this is another study, it's very interesting because we have, yes, been reached from some patients doing sleeve gastrectomies that have some symptoms of dysmotility of the esophagus. So they got a cohort of 1,000 patients, and they studied 49 patients that did have symptoms of this dysphagia, but that did not have anything on the endoscopy. So there was no problems, organic problems, structural problems. And what they did find there was a large amount of patients that after the exam showed dysphagia with the prevalence of showing high rates of achalasia after the sleeve gastrectomy. This is a study that here he doesn't describe the technique he uses, but what we do know, we are observing now that some surgeons are using to achieve very nice control of weight using just thinner and thinner bougies, and we are seeing that this is bringing a lot of problems, not only complications but esophageal and gastric dysmotility. So this is something interesting we should really discuss, because I see in most part of meetings we're still discussing the size of the bougie, what result we should get, and I think this is very important to discuss, that if we go too tight, maybe we'll have problems and worsening of the whole upper GI motility disorders.
This is quite interesting. Even in a normal pre-op manometry, you still have that risk, which raises the question: should we do manometries pre-op? Because some patients in previous studies had pre-op achalasia as well.
Very nice. Okay. Oh, this is something very interesting. You know, here in Brazil, we do this. We got counseling before, and we really give a lot of importance for the counseling after with the multidisciplinary team. I know we already have discussed this to go for a consensus and Ifso about this matter. So what is interesting here is showing that really it is important for the final results that these patients have very good attendance after the surgery for a long time. But one thing interesting here that he showed is that the pre-op counseling is important. And I really, after reading this, I got some sort of conclusion, because here we do counseling before and we really didn't understand the importance. But after reading this, I think this counseling pre-operatively is not only to prepare the patient for the surgery, but to get the patient aware the importance of doing it after the surgery. So I think this is a very nice study showing the numbers, showing that they will have a high postoperative attendance, the patients that did the preoperative, and the results are really nice if the patients go ahead with all the counseling sessions with the interdisciplinary teams.
Definitely an interesting paper, and something I will look forward to reading, hopefully if they publish it, to look at what they exactly do in details in counseling those patients. Thank you, Caetano, very much.
Thank you.
Pedro?
Okay, I'm here. Thank you, Ahmad. Let's start with this abstract presented by Carvalho from Spain about when anastomosis gastric bypass key step toward standardization of the procedure. The aim was to illustrate key operative steps visually. They include 3,400 cases from 2002. They describe how they change the patient and surgeon position to facilitate the small bowel measurement from the trach to the ileocecal valve. They use 6-stroke technique also to measure comfortable. The biliopancreatic limb is usually about 60% of the total bowel length. Next slide, please. And the common limb is usually 40% of the total intestinal length, and they perform long gastric pouch of around 18-20 centimeters. The first fire starting around 2.5 centimeters from the pylorus. They also perform an anti-reflux mechanism of 8 to 10 centimeters between the stomach and the small bowel with running suture. Next, please. The size of the GJ is 30 millimeters using the anterior gastric pouch wall. The close of the GJ could be done with simple stitches or one layer running suture. The result, the long-term follow-up has demonstrated an excellent balance between safety and efficacy, with low rate of short and long-term complications and high rate of excess weight loss, 88% in 2 years post-op, and most of the patients have remission or improvement of comorbidity. In conclusion, one anastomosis gastric bypass is an outstanding option for primary and revisional bariatric surgery. Okay, next.
Thank you, Pedro. I think this presentation actually sheds light with amazing pictures that were not there in their initial description. So thank you, Dr. Carvalho, for adding those interesting pictures and detailed description.
All right. Okay, this study is the effect of bariatric surgery on cardiovascular risk. The aim was to calculate the effect of bariatric surgery on hypertension, antihypertensive usage, lipid profile, and familial risk score over 2 years, including 552 patients in the study from January 2009 to September 2018. Next slide. % were female. The mean age was 47 years old. 67% underwent laparoscopic gastric bypass. 8% were smokers. The mean systolic and diastolic blood pressure decreased progressively, while the mean high-density lipoprotein and total cholesterol increased progressively. The next, please. The antihypertensive usage decreased significantly, and familial risk score decreased too. In conclusion, bariatric surgery reduced the 10-year risk of stroke or heart attack by 58% in their patients. Very, very interesting paper.
Definitely very interesting study, Pedro. And it adds to the recent paper that we discussed in the Journal Club by Dr. Ali Aminian and the Cleveland Clinic group, how effective bariatric surgery is in the cardiovascular risks long term.
Exactly. Okay, the last one is a comparison of the different biliopancreatic limb to total bowel length ratio in digitalization of room-wide gastric bypass for weight recidivism. The aim was to optimize operative outcome of distal room-wide by comparing different biliopancreatic limbs to total bowel length ratios. It was a retrospective review of 37 patients who underwent type 1 distalization of room-wide, dividing the root limbs and lengthening the biliopancreatic limb for weight recidivism. By weight recidivism, they mean BMI over 35 or less than 50% of excess weight loss. The mean BMI was 43 and the mean follow-up was 18 months. After measuring the total bowel length, they divide the patient in two groups. Group A with 16 patients who had less than 30% of biliopancreatic limb, and Group B with 21 patients who had more than 30% of biliopancreatic limb. The root limb was 100 centimeters, maintaining a total alimentary limb length total of 350 to 400 centimeters. Next, please. Result, the percent of excess weight loss were relatively higher in the Group B than in Group A, 65 versus 59%. There were no significant difference either in the resolution of comorbidity or in morbidity rates. In conclusion, when performing distalization and room-wide, they recommend a biliopancreatic length of 33% with a total of 350 to 400 centimeters to maintain balance between optimum results with minimal nutritional complications.
Thank you, Pedro. And that's about the power of the biliopancreatic limb. The longer it is, the more weight loss, with a lot of randomized controlled trials to establish the perfect link and its effect on the nutritional outcomes. The longer you go, the more nutritional deficiencies patients will experience. Thank you, Pedro, very much.
Thank you.
And thank you. Zahir is unfortunately unable to be with us. Zahir Toumi is one of the new members of the communication committee, and look forward to having him as a very active member in the committee. And his first study looked at the vagus nerve sparing in one anastomosis gastric bypass and its effect on the gastrointestinal quality of life. And they had two groups. Unfortunately, from the abstract, we couldn't know if it's randomized or not. It was done in Egypt. And the vagus nerve preservation group had improvement in the GI symptoms and had a better GI quality of life index score. They had less nausea, less regurgitation, vomiting, abdominal pain, bloating, flatulence, belching, and bowel urgency, as well as bowel movements. That's one of the top abstracts that was presented in Ifso Madrid. Anybody has any comment? Anyone doing one anastomosis, looking at the vagus nerve and preserving the lateral J?
We don't, unfortunately, we don't do that in Brazil yet. One anastomosis is not yet a surgery approved here. Pedro, do you have any experience?
It doesn't seem so. So the next slide is a prospective database in Egypt, looking at 36 patients who had preoperative NASH, non-alcoholic steatohepatitis, and diagnosed by liver biopsy, either during another procedure or percutaneously. And within these 36, 23 had active NASH, 12 had steatosis. After bariatric surgery at a median of 25 months, only 4 patients had non-alcoholic steatohepatitis, and the rest actually had remission. And they found that the patients who have aggressive metabolic are the ones that improve best with better weight loss. The following study is looking at the long-term malignancy after bariatric surgery, and that's the question that's being raised recently, especially with the recent concern about increased colon cancer after bariatric surgery. It's a retrospective study on if it's matched 3 groups: obesity plus bariatric surgery, as opposed to patients with obesity who did not undergo bariatric surgery versus the general population. And they found that the lowest risk of cancer was within the bariatric surgery group, even lower than the general population who do not have obesity as an issue, which is a solid and great study and a major contribution to the cancer questions.
That's very interesting, this study, because there's a lot of other studies relating cancer with BMI. The bigger the BMI, the higher the risk for cancer. So this is very interesting.
Looking forward to the paper for sure. Moving on to Aparna, Dr. Gulbal Bhaskar, and her first paper is a unique paper on connected devices in the post-operative period. I know you had the short time to look at this study, but this study was done in sleeve gastrectomy patients who were discharged with enhanced recovery protocol 24 hours after surgery, and they were hooked to wearables, many wearables that were not described within the abstract, but 100 patients, 2 excluded because of the being operated on within 24 hours. 1 patient actually had tachycardia, fever, and mild abdominal discomfort that triggered the online alarm. He was called back, he or she was called back and operated on. Other patients did not have any problems. However, the patients who did not physically follow up, they recorded, their weight was recorded online, and no losses of data points were noted within the abstract, and 92% of patients felt safe and recommended such platform to all patients. Aparna, do you think this is the future of bariatric surgery?
Yeah, I think so.
Yes, definitely
Yes.
looking forward to what they used, and the more tools we have, the better we are able to care for our patients.
Yes, definitely. So
Aparna,
should we
please
go on
go
to
ahead.
the next slide? Yes.
Yes.
So this is a very interesting paper from Saudi Arabia, and I think very pertinent as well, because this identifies reasons for bariatric surgery patients' non-compliance to post-operative physician recommendations. So basically focusing on follow-up after bariatric surgery. Next slide, please. Yes, so the objective of the study was to identify the reasons for post-bariatric surgery patients who were non-compliant with the follow-up, vitamin supplementation, physical exercise, and cessation of smoking. So a telephone survey was conducted for these patients who underwent either a primary sleeve gastrectomy or a Roux-en-Y gastric bypass between 2013 to 2017. And the demographic and clinical data was collected from their records, and minimum post-operative period was 12 months. Now, some of the reasons that really stood out, before that, actually about 77% of the patients responded to the survey, and 58% out of these were uninsured, but this actually did not impact the findings. 51% of these patients had RYGB, and 60% of the patients actually stopped follow-up with the bariatric team, and the reasons are as under. So about 27% were following up with the primary care physician. 25% felt that follow-up was not necessary at all. 16% did not have any time for follow-up. 40% of these patients actually discontinued vitamin supplementation. 66% felt that vitamins were unnecessary, and 15% actually responded to have side effects with the supplements. 51% patients were not exercising, and 28% of the patients continue to smoke. 28% smoked pre-operatively, and out of these, about 80% resumed smoking after quitting in the perioperative phase. And out of these, 75% responded it as a stress-related or lack of access to cessation programs. So I think this is extremely important, and like the previous abstract suggested, that the pre-operative counseling of the patients is extremely important to stress upon the importance of follow-up post-surgery.
Definitely raises the question if we should use wearables and the other means to communicate with patients in the
Yes.
previous abstract as well.
Yes,
both
and absolutely. And the findings are similar across the world, because I remember a paper from Dr. Higa where he said that the follow-up rate was actually only 7% at the end of 10 years. So that's in US and this is in Saudi, so it's just the same. Yes. Can we go to the next one, please? Yes. So the next study is by Dr. Vijay Lee, and it talks about variation of small bowel length in bariatric patients, and does it influence the outcome after bariatric surgery? So small bowel length has been of interest. I think we've seen it in the previous abstracts as well, especially for the treatment of type 2 diabetes. And the aim of the study was to investigate the variation of small bowel length and whether it has any clinical significance. So small bowel length was measured in about 620 obese patients who were undergoing bariatric surgery, and the demographic and clinical data was collected and stored prospectively. And patients received sleeve gastrectomy was specifically investigated on the relationship between small bowel length and weight loss. So not just the bypass, but the sleeve gastrectomy patients were studied particularly. And the results were that the small bowel length was found to vary widely between individuals, and it could range anything between 380 to 1,000 plus centimeters. And the linear regression analysis showed a significant relationship between small bowel length and height of the patient, weight of the patient, waist circumference, LDL levels, hemoglobin, C-peptide, HbA1cs, and RGT. Multivariate analysis confirmed that height and HbA1c were the independent predictors of bowel length, and small bowel length did not influence weight loss 1 year after bariatric surgery. So whatever the variation was, it had no effect on weight loss. And the conclusion was that yes, it varied widely in bariatric patients, and it was related to the body height and HbA1c level, and it did not influence the weight loss after bariatric surgery.
Interesting concept to do it within the sleeve gastrectomy group, and I wonder if this is pertinent in bypass operations and creating limb lengths, and I think this is where the influence will be.
Right. So.
And it stresses the variability of the length of the small bowel in creating biliopancreatic limbs and going too long, which will shorten the common channel in certain patients.
Correct. But I think there would also be an issue about increased OR time by measuring small bowel length in everybody and causing injuries as well.
Yes, it's definitely not without risks.
Yes.
Definitely. Thank you, Iparna. Thank you very much.
Thank you so much.
Unfortunately, Ali Aminian is not able to attend due to work commitments, but he's three very interesting abstracts. This is the cost of anti-hyperlipidemic agents in sleeve gastrectomy versus Roux-en-Y gastric bypass in a randomized controlled trial done in New Zealand, where they randomized two arms, blinded, and looked at the results last 3 years. They published their first year results, which showed no difference in cost between the two arms. They randomized 58 patients to sleeve gastrectomy, 56 to gastric bypass, and looked at the medication cost to the government for anti-hyperlipidemic agents preoperatively and at 36 months after surgery. And their results were quite interesting. Despite no significant differences in reduction of medications within the two operations early on, at 36 months, the trend became statistically significant for Roux-en-Y gastric bypass, decreasing the medication cost to as low as $543 as opposed to $1,541 in sleeve gastrectomy. So to them, doing gastric bypass to diabetic patients seem more cost effective. One interesting study, anybody has on this study?
Actually, I have a comment, Ahmed. I think it just highlights that when we see a diabetic patient, we should not just look at the diabetes. There's also randomized studies to show that hypertension improvement is significant. So it's not only about sugar. None of the patients I see in my office who are diabetic only has diabetes. They seldom have hypertension, dyslipidemia, and reflux, and other things.
I definitely agree with you, and it's such an interesting concept to look at not only remission but cost within the population. So something that we probably all should look at. The next study is a population-based matched cohort on mortality after bariatric surgery, and that's done within the Canadian system, Dr. Anbari's group. And they linked many administrative databases to look at the most causal link between bariatric surgery and mortality to date. So what they did between 2009 and 2016, they matched patients based on age, BMI, sex in a 1-to-1 ratio with the non-bariatric surgery general population, and looked at multiple confounders as comorbidities, healthcare utilization, socioeconomic status, smoking, substance abuse, cancer screening, or psychiatric history. And the interest is they found that bariatric surgery among all groups, age, BMI, as well as gender, actually reduces mortality. Bariatric surgery reduces death by 50%. Those who were older than 55 years of age had actually a lower death rate as opposed to the control group. And those with BMI 40 to 50 had even a higher survival advantage in the bariatric surgery arm. Males did a little bit better than females. However, both did better than the control group. So it adds to as well the recent paper that we discussed in the Journal Club with Ali Manian showing the advantages of bariatric surgery. The last study, which is another interesting study that defined global benchmarks in bariatric surgery within centers of excellence, and how do we define quality in bariatric surgery among Roux-en-Y gastric bypass and sleeve gastrectomy. So they basically looked at 19 high-volume academic centers, more than 40,000 patients, and identified a little bit more than 4 Roux-en-Y gastric bypass and about 1,500 sleeve gastrectomy low risk cases to actually just define quality within those centers, and excluded a lot of complicated patients. They looked at the complications were graded according to the comprehensive complication index and the Clavian-Dendo definition of complications, and they defined the highest quality as the 75th percentile of outcomes. And it has a nice table. You can see it. It's probably not very clear, but looking forward to the paper. But if you look at the numbers, the Roux-en-Y gastric bypass group, a high quality Roux-en-Y gastric bypass has to be done in less than 2 hours with no conversion to open, no need for intraoperative blood transfusion or post-operative blood transfusion, very low ICU stay, less than 4 days in the hospital, and they even estimated the cost within the US system and the European system. And they looked at complications. More than 94% of patients have no complications until discharge, 91% within 30 days, and more than 90% within 30 days and 90 days. And they defined it reoperations complication, and it's a very interesting use and a very interesting definition to quality. And if you compare it to sleeve gastrectomy, a good quality sleeve has to be done less than 1.5 hours, no convergence to open, no need for blood transfusions, no need for ICU stays, and a hospital stay less than 3 days with a defined cost to the system and a definition to morbidity and mortality. Something that is good to use and very interesting. And thank you, Ali, for reviewing these nice abstracts and adding to the presentation. Final comments from the group.
I think it was a very nice revision of very, very nice studies and resuming the whole idea of this meeting. That was fantastic. Congratulations for all the committee that participated in organizing it. It was fantastic. And this meeting was nice.
Thank you, Caetano.
Well, personally, I've enjoyed all the presentations. I'd like to thank Ahmed Bashir and all the presenters and panelists for summarizing the top papers that many people may have missed at Ifso at Madrid. I'd like to remind people who've been watching that tonight's presentation has been recorded and will be available on the Ifso website. The slides are in PDF form. It'll be in the Academy part of the Ifso and also the handouts as well. I'd like to congratulate everyone for a wonderful presentation. I've really enjoyed that 1 hour of summarizing of all the great papers that was presented. I know there were over 1,000 presentations, but these were the cream of what was presented in Madrid. And thank you everyone for presenting these abstracts in such a succinct manner.
Thank you, Dr. Kell. Thank you, everyone. The communication committee, everyone, please reach out to any member if you have any ideas how we can improve on what we do, and looking forward to seeing you next month in a new journal club and a new webinar. Thank you, everyone.
Bye-bye, folks.
Thank you.
Thank you.
Bye-bye.
Thank you for the day.
Thank you.